Okay, so like Dr. Schultz and Susan said, spina bifida is a very complicated diagnosis, and that means that there are many seating options available for kiddos and adults who have spina bifida. I think it's a pretty common misconception that you can just put someone in one of those wheelchairs that you see in the front of the hospital that just kind of fold together really quickly, and you can just put someone in that and call it a day. And unfortunately, that is not the case. They usually need a lot more supports and different types of components than just being able to fold. I think we've kind of touched on a lot of different issues, so I'll try not to go too much in depth. But poor positioning can be very detrimental to people's function. It causes orthopedic injuries such as scoliosis and contractures and also skin breakdown. I think that some lesser known components of positioning are feeding and swallowing and GI function. And if you you're sitting there and if you slunch over like this, you're going to notice that it would be really hard to eat if your face is Are we okay? Okay. If your face is hunched over like this, gravity is going to pull down on your face and make it difficult to chew. And then also if you're slunched down like this, you're going to have impaired GI function. And also, if you're looking down, you can't see the world, you can't interact with your environment or your peers. And also it's going to affect your lung function and breathing. So that is why positioning is so very important. We want to sit upright so we can eat, we can breathe, we can function appropriately. And also, like we mentioned, spina bifida is a progressive diagnosis, so you know that things change as people age, and often their function can decrease. So that means that it's not unheard of for a kiddo to be ambulating until they're whatever age. I just saw a kiddo who was ambulating until he was 9, and then he just kind of got tired of participating in the PT that was necessary to maintain his ambulating status, so then now he needs a wheelchair. And that happens very frequently throughout the lifespan. And there's not really any set in stone time where a kiddo needs to come to seating clinic. Sometimes we see kids as young as 6 months old, and we'll try to recommend maybe not an adaptive piece of equipment, but how to modify equipment at home to provide extra support. However, like I said, it's not set in stone. On Friday, I saw a kiddo who was 7 months old, and we recommended an adaptive stroller. But basically, like Elena said, as soon as a kiddo is showing an interest in exploring their environment and getting up and moving around, it's time to look at what equipment is going to help facilitate that. Because in the end, the goal of seating and mobility is to provide a means of mobility for people to participate in functional activities, whether that's in the home, getting themselves from the living room to the kitchen so they can get themselves a glass of water, or to the bathroom, or in the school, and so they can drive themselves through the hallways and out in the community. So quickly about the awesome seating clinic at Kennedy Krieger Institute. Usually the team is made up of a therapist and a vendor, and the therapist can be an OT or a PT. It really depends on the experience and expertise of the therapist, and then also the equipment devices that someone is looking for. A general rule of thumb is that PTs will take referrals for gait trainers and walkers and crutches, and here at our seating clinic, the OTs take referrals for wheelchairs, strollers, bathing equipment, activity chairs, power wheelchairs, all that good stuff. But that doesn't mean that's how it is everywhere you go. And then the vendor is the patient's choice. It doesn't have to be a specific vendor, but the representative from that company is usually an expert on equipment, and then the therapist is an expert on the person and their function. And so together we all work together with the parents' input and obviously the patient's input on how to find the best equipment for them. The number one thing that we look at for people with spina bifida are appropriate cushions, like seat cushions and back cushions to make sure that they are being provided with the proper support. Like I mentioned earlier, you don't want to be slumped over, so they're going to need a supportive back with laterals to hold them upright depending on the level of their lesion and depending on their trunk function. If they have really weak trunk strength, which most of the people with spina bifida do, they're going to need some form of lateral support to prevent them from leaning to the sides like that. And then a seat cushion is also very important to prevent skin breakdown, because a lot of these people are in their wheelchairs up to 16 hours a day, which is a lot of time sitting in one position. So we want to make sure that there's some kind of foam and gel over the bony prominences to make sure that they're not digging in there causing pressure sores. So I will quickly go over a few types of equipment. Keep in mind this is a very small selection, and just these are demos, so the components can be changed on all the different equipment, and a component would be a headrest, or seat belt or laterals or anything like that. Sorry, I'm being told I need to get this show on the road. So this is going to be an adaptive stroller, and you can see they tried to keep a stroller look to it. It's for younger kiddos that are non-ambulatory, and it has really good lateral support there, and it also tilts in space to offer pressure relief. If a kiddo is capable of propelling their own wheelchair, we would not recommend this, because we want them to be as independent as possible, and this warrants them dependent for mobility.
Oh. Do you want to take that?
Yeah, you can lift it up.
Oh,
you don't think you can do it all by yourself?
I was worried about that on camera.
All right, so this is one version of an adaptive stroller. So I'll wheel that precariously right there. All right, and this is a very adorable little manual wheelchair for little kiddos. Sorry. So this is going to be for someone who can propel themselves. And you can see that they make wheelchairs for very, very small little kiddos, because usually a child is going to start exploring their environment by crawling and walking. A typical child would be between 6 and 12 months of age. So we want to parallel that for kiddos who have spina bifida and are non-ambulatory, because we want them to explore their environment as well. So you can see that they can drive themselves and get all over the place. And this is a power wheelchair. It's not very common that people with spina bifida need a power wheelchair, because they usually have functional upper extremity strength, but like everyone's touched on, over time, over their entire life, they can have shoulder injuries, carpal tunnel, things like that, that would warrant them unable to propel themselves, or they would need something for long distances like that. And this also can tilt in space like that, so it can perform pressure relief. And Terry touched on ADL equipment. And I did, since we were talking to case managers, I did just want to point out that insurances do vary depending on what item of equipment they'll cover. MA will currently, unless they've changed in the last 72 hours, they will currently provide bathing equipment for younger kiddos. It's just that when they get older and into a Medicare age or past their 20s is when they kind of stop paying for bathing equipment. And that goes for toileting equipment as well. But like Terry said, insurance will not cover any kind of in-home positioning or activity chair system. It's considered a convenience item, but that doesn't mean that kiddos don't need it, and it doesn't mean that we can't somehow get it for them. We just need to be a little more creative in how we can go about procuring their equipment. So that was OT and PT in a very quick nutshell. You had a question?
I do. I just want to make a comment to in general, when you talk about therapy recommendations to come in addition to school therapies, just to know that insurances won't pay two therapies on the same day. And that's something families really need to know.
That's a good point.
I have a question about the adaptive stroller. Is that billed as a mobility device, and if so, does that mess you up when you're time-wise when the child is ready for a wheelchair? So how long do you recommend that? I'm looking at when we reorder equipment.
That is an excellent question. So that is one of our jobs in the seating clinic, is to kind of determine what their function is, and if it looks like a kiddo would be able to self-propel a manual wheelchair in the future. And if it does look like in a year this particular child would be able to propel themselves around, we're not going to recommend an adaptive stroller at that time, because we want the opportunity to stay available for them to get a manual wheelchair. There's no hard and fast rule on insurance that they get a new chair every X amount of years. Insurance wants to know why they need a new chair. Has there been a change in medical status or growth? However, if we get an adaptive stroller for a 1-year-old and then they turn 2 and they need a manual wheelchair, insurance is usually not going to approve that. Does that answer your question? Or?
My question is, so when you're looking at it at 1 year, we need to keep in mind that potentially this child will need a wheelchair and therefore not get it then.
Yes.
I'm having a problem with the child. I'm sorry to get off topic, but the child has CP. The child does not have spina bifida. And at 2.5, he was ordered a manual wheelchair. Now he's school age, 5. The school wants him to have a power wheelchair. He has the cognition, he has the ability, and we can't get insurance to pay. And the vendor won't even look at it. I'm not going to start evaluating him for a power wheelchair because he's in REM, medical assistance, and we're in a mess. I can't get funding for a power wheelchair that easily.
It is difficult.
Had they looked at 2.5, about, you can't predict what his needs were going to be.
It is difficult to predict.
It's problematic when we're looking at equipment over the spectrum.
It is, and we can talk about it at the end. Maybe I'll try to catch you before you leave to talk more specifics about that particular situation, if that will help.
Do you pressure map?
Yes, we do pressure mapping. And for those of you who don't know what pressure mapping is, it's a computer system where it can provide a back and a seat, and the person sits on it, and then on the computer screen it shows the areas of pressure that they put on certain parts of their body. So it'll show up in colors, and you can actually see the bony prominences, and if they're putting significantly more pressure on their left side or their right side, or if it's in the center, or if they tilt forward when they sit, and then that can help determine an appropriate cushion if we're very stuck with just feeling with our hands. Any other questions? All right, thank you.
I would now like to introduce Dr. Andrew Zabel, a pediatric neuropsychologist and research scientist at Kennedy Krieger Institute, who will discuss cognitive issues in children and adults with spina bifida and his research findings.
Okay, thank you. My name's Andy Zabel. I'm going to be talking about cognitive issues in spina bifida, and this is one of those things where you have to be careful about living in a glass house because everyone has their own cognitive issues, and I have mine. I forgot to bring an umbrella today and got my hair wet walking over here and tried to dry my hair under the hand dryer in the bathroom, which shows poor planning and yet very ingenuity as well. So that's why my hair looks like this, Tony. So anyway, I'm gonna start with this, and one of the important things, since we're talking about You're
fine.
Oh, okay. Okay. Susan Demetrides, what's the name of this conference called? Right, prevention of secondary conditions. And so what's really important here is that we use all the clues at our disposal to avoid cognitive problems and school-related issues and things really going off track. And one of the first things we can use to identify risks for preventable cognitive conditions or a cognitive condition that you can intervene with is the brain scan. Oftentimes, this is very much used for the identification of hydrocephalus, but there's some clues in here that people know about and should know about, and oftentimes neurosurgeons will tell you that these things, you can only tell so much from a brain scan. Well, you can tell a lot from a brain scan based upon the cognitive neuroscience at this point, and these are 3 things you want to watch for because they elevate the risk of cognitive problems. The first of those is the Chiari malformation. Now, this is something that most people know about, but that's a malformation of the brainstem and cerebellum. So that's what we want to be on the lookout for that. But the 2 that you may not be as keyed into, which are really important findings and are linked with more complicated learning disabilities, are, do I have a, oh, look at that, okay, are tectal beaking. And so the tectum is right up here at the top of the brainstem, and you see how it points out there like a little beak? Can you see that? That means that the cerebellum has kind of rolled up under there, and that's a common malformation in spina bifida, but it's not present in everybody. And when it is present, that suggests a higher level of, it's been associated with a higher level of cognitive dysfunction. So it's something you want to jump on right away when you see that brain scan. And then this is the corpus callosum. Dysgenesis means that it's underdeveloped, and this is where it typically underdevelops. It should look the same on this side as it does on this side, and here it doesn't, and that's another very common finding in spina bifida. And if you just use those 3 things, the presence of a Chiari, tectal beaking, and callosal dysgenesis, you can typically, you can pretty much identify most of the kids with spina bifida that are going to have complicated courses in terms of their cognitive development and learning. That's kind of helpful, yeah? All right. So there's been, I'll jump through this pretty quickly, but what's so fascinating now is that we have a cohort of individuals with spina bifida who are in their 50s and 60s, and it's really hard to really know what that means for individuals growing up now, because those individuals probably had less complicated courses, and we are intervening with kids that are much more complicated and keeping them alive, keeping them healthy, and getting them to adulthood. So we really need a lot of emphasis placed upon research that will help us understand what this all means. Clearly, it was important when the shunt was developed because that saved a lot of kids' life. That's John Holter down at the bottom left. And that's Roald Dahl, the children's book author, at the upper right. Both of them were instrumental in shunt development. John Holter was just a mechanic who tried to save his son's life there with spina bifida in the bottom right-hand corner of the picture. It was unsuccessful. He developed the Holter valve for the neurosurgeons. Unfortunately, he couldn't save his son's life, but he did help with other kids. And then Roald Dahl helped develop another shunt that helped kids who didn't respond to the Holter valve and actually had more hemorrhagic hydrocephalus, and he helped develop one of those. So fascinating people that have helped extend the lifespan of kids with spina bifida. This is Jack Lapidus. I think I'm saying that right. He introduced shunting, catheterization in the 70s, and this made a huge impact upon individuals with spina bifida, and certainly with urinary care. The Hib vaccine was big in terms of saving kids' lives because you open up a kid's head too many times, they're going to get meningitis, and one of the most common causes of meningitis was treated by this vaccine, and a lot of that was simply eradicated. And then the MRI has been crucial in terms of identifying kids who have gone into crisis. I bring this up only to say that we don't know how the kids that we're looking at now are going to be based upon the research we have, because they're very different. There's been new technologies that have saved lives, and we need to see what they look like now, but they're probably more medically complicated, and the risk of cognitive problems is probably even higher. One of the biggest developments in spina bifida research has been the identification of what we call a cognitive phenotype. A phenotype is a pattern of behavior around either a genetic condition or a condition with at least some genetic basis like spina bifida. These are real pioneers in research, and we've got some of the best cognitive researchers and they're in spina bifida. That's Jack Fletcher on the left, Maureen Dennis in the middle, and Marcia Barnes on the right. They've really gone, just done beautiful work in helping us understand the cognitive phenotype of spina bifida and how these kids learn and present. Now, fortunately or unfortunately, a lot of people have linked the idea of nonverbal learning disability to spina bifida. And while that's been useful to some extent, you have to understand that there's multiple conditions linked to nonverbal learning disability. They tried to, tuberous sclerosis, why am I blanking on this? Traumatic brain injury, autism. There's all kinds of different conditions that have been lumped into nonverbal learning disability. And these researchers really thought we can do better and not have spina bifida lumped in with the general category, but find the specific phenotype, and that's exactly what they've done. So while nonverbal learning disability isn't a horrible model for spina bifida, there's a better model that I'm going to tell you about briefly, because identification of these kind of learning problems is halfway to preventing them. This is far too complicated, but what I want you to see is at the bottom, the neurophenotype is based in great part upon these malformations I just told you about. So while nonverbal learning disability thinks a lot about the brain's white matter and hydrocephalus, with spina bifida, it's at a deeper level, and it's all about that Chiari malformation and some of the other midbrain and brainstem malformation. And that's what makes spina bifida unique to anybody else with nonverbal learning disability, because they don't have that. They've got white matter dysfunction in nonverbal learning disability. We have a specific group and cluster of learning problems associated with those midbrain and brainstem functions. Now you can see up here, hydrocephalus certainly complicates it, but that's a secondary injury that just makes things worse. It's not because of the hydrocephalus. The hydrocephalus just increases the burden. And then I'm going to get into some of this other stuff real quick, but this slide's too complicated. In the end, it comes down to this. Kids with spina bifida have strengths and weaknesses across domains. They have strengths and weaknesses in verbal areas. They have strengths and weaknesses in nonverbal areas. They have strengths and weaknesses in reading and in math. Okay? So it's not about just having one domain where they're bad and one domain that they're good. It cuts across all of them. And it comes down to this. I'll just keep going because I can ignore that. It comes down to this. Kids with spina bifida do very well with associative processes, or association learning, all right? They can link one thing with another. They can link one word with one meaning. They can link one set of letters with one word. This is why they jump out of the gate typically in school doing fairly well. Teachers like this because building these associations gives you a very good start, and that's what they're focusing on. Where they have trouble is the assembly processing, where they construct meaning out of individual parts, okay? And so the prototypical example is reading, where individuals with spina bifida will do very well at finding, that word, I can read that word, and they can read all the words, but building meaning and inferring things and, coming to conclusions out of that and assembling meaning, that's where the breakdown occurs, all right? And so there are things to be watching for along the life course here, because this basic problem manifests at different points in different domains. So, for example, language. There's been a lot of talk about this cocktail chatter syndrome, where kids with spina bifida have a lot of language, but if you really look at the level of narrative discourse, there's not as much meaning as you might expect with all the language that's generated. And that kind of can be explained by this, where the word knowledge and retrieval is a strength. So there's lots of language produced, but constructing and updating meaning in speech is where the research shows that the problems occur. And that happens right out of the gate. Reading in spina bifida, as I just told you, the strength is in word decoding and sight word reading. Those are areas of strength for kids with spina bifida. The problem becomes reading for comprehension, drawing inferences, and conclusions. This one goes off the rails right about 4th grade, and that's where the kid's been a good reader up till now. What's happening? Why can't they do this? And it's because this is happening and this problem is manifesting at that point in time, and we really need to be ready for it, because at this point it's just downright predictable how it happens. Okay? So the reading supports need to be introduced at this point or earlier, and oftentimes they're not, and kids can really go astray in terms of their learning progress. In math, it happens a little bit earlier, but math isn't the primary focus of most educational programs in the early years of education. So the association piece of it is kids with spina bifida typically learn math facts fairly well, or maybe a little delayed in that, but eventually do. The problem really comes down to math procedures. So knowing to, learning to regroup or rename, or we used to call them borrowing and carrying, but it's the same thing. Learning that and then using that consistently is really a problem with spina bifida, and this oftentimes gets identified in 2nd or 3rd grade. We have testing now where I can identify this probably in kindergarten, though, and identify the kids that will have problems with this in 3rd grade, and we can introduce those interventions earlier and earlier. But again, we need to be screening them and identifying them. So with reading, it's usually in 4th grade. With math, it's early on. I can detect it in kindergarten, but it may not be really detected and manifesting in the school until about 2nd or 3rd grade. Okay? I'm going to talk a little bit about self-management. I know you've heard a lot about different things like catheterization and seating and positioning, and you may have even heard about headaches, and there's a lot that goes into managing your own condition here with spina bifida. And as kids are living longer and longer, the burden falls increasingly on them to manage this once they leave the home and transition into adulthood. That's really tricky because it's a lot to keep track of, and if there's a cognitive problem on top of it, we've got a double whammy of more that's expected of these kids and more of a cognitive problem, that gets in the way of it. So you like my wheelchair push-up over there? That's really hard to remember to do those things, especially if you're not having a physical sensation cueing you to shift your weight. So this is Mark Mahone, who's a research scientist and my mentor here at Kennedy Krieger. And I'm going to talk just briefly about executive functioning because it has a lot to do with that self-management piece we just talked about. So kids with spina bifida, the research shows, oftentimes have difficulty with initiation, so initiating things that they know how to do already, working memory, and prospective memory, which is just a fancy way of saying remembering to remember to do things in the future, and planning and organization. So if we think about the example of self-catheterization on this, you may ask a kid who's having trouble cathing regularly, when am I supposed to cath? And they will tell you 8, 12, 4, 8, and then before bed. And they can do that, but that doesn't mean that they're going to initiate it or remember to do it at those times. So, and that doesn't mean that they're going to plan and bring all their catheters with them on the weekend when they go out and, think I'm going to be, away at 12 o'clock and 4 o'clock and I should bring these things with me. That's where it all breaks down, or it breaks down on other aspects of self-management. So we've got a lot of great technology, and that's not the focus of this conference, but there's a lot of technology that is being implemented now to help cue and remind in a way that doesn't feel like nagging. And the best thing I think you could do for a kid with spina bifida is buy them a smartphone. It's got all the bells and whistles, and they love it, and they're not going to lose it. You buy them a watch with a buzzer or a timer or a pager system, they will lose that thing right away. But that smartphone, I haven't encountered any kid with spina bifida that's lost it yet. Now, to me, that's saying a lot. And there's actually new technologies being developed by the University of Pittsburgh, a whole spina bifida self-management program where they're going to have it's going to be tied in with case management services as well. So if you forget to log in that you cath, you will be getting a call from Central Station Monitoring. All right? So executive functions are a problem. Self-management is an extra burden, and these interact like this. Okay? So you've got adaptive demands, typical and high, and you've got executive abilities, typical and impaired. And we start with, the kid who's typically developing has a normal amount of adaptive expectation and a normal amount of executive ability and typically does okay. Kids with high, but look at spina bifida in that bottom corner, impaired executive ability and high adaptive demand. We think that it's a double whammy. It's not just a matter of educating them about their care or teaching them about their care. You need some sort of reminder system or cueing system to supplement that. You need both in terms of an intervention plan. The Chesapeake-Potomac Spina Bifida Association has been a big supporter of my research, and as a result, we've come up with our own questionnaire about these self-care demands and the executive demands of spina bifida. We call it the Kennedy Krieger Independence Scales. So we now have norms for how, when should someone be kind of self-cathing on their own and initiating that without parent intervention? When should they be doing their bowel program without reminders? When should they be doing, be independent in terms of wheelchair push-ups if they have to do that? So we've got this great information, and I'm here to tell you that, if we look cross-sectionally, it looks like it gets better over time. This is our initiating routines scale, and these are the items on it. But beginning clean intermittent catheterization on time, getting out of bed on time, finishing morning hygiene on time, taking medication on time, and even cleaning room and finishing chores, those are all going up over time from age 10 to 12 all the way to 23 to 29. It looks like it's getting better. That doesn't happen in a vacuum. That's parents and providers like you kind of inspiring and supporting growth. But it does happen over time, and we have information about it now to suggest that what we're doing is helping. Preventable conditions, one that you really need to be on top of is depression. And the research is coming out pretty strong now that young adults with spina bifida struggle with depression and anxiety at a higher level than you would expect for the population as a whole, and even higher than you might expect for someone with a medical condition. So it's really important to screen for that. But as research has started to look further and further back, we're finding that it's really evident in teens with spina bifida as well. So it's probably never too early to start screening for depression and anxiety, particularly in females and particularly in females with pain. That's the most vulnerable population according to the research literature at this point. But everybody should be screened for this. And this is Mel Bellin and Kathy Sawin, who are really instrumental in this research. Last thing I'll say here is family functioning is really important as well and very complicated in spina bifida. This is Grayson Home back at Loyola University in Chicago. And his research would suggest that families of individuals with spina bifida have a delay in the separation process. And there's actually less conflict between parents and individuals with spina bifida as they're going through their teenage years. And some people in the room may beg to differ. I don't know. But it looks like as a whole that there is a shift and the conflicts happen later. And that may be because the social support systems are so can be limited with individuals with spina bifida. So if you're relying solely on your family, you're not going to try to mess that up with a lot of conflict. If you've got a supportive peer context, you may be more inclined to start that separation process by pissing your parents off. But in the end, we know that it's delayed. And we also know, and it's hard to say this without being derogatory, that there's a degree of protectiveness of parents that is really important for parents of kids with spina bifida, but also it's this interesting dance because you have to give opportunities for failure too, or for opportunities to succeed without help too. So parents are really in a tough spot where protectiveness is kind of the default functional way that the family works, and yet there needs to be opportunities to kind of try things without as much help or protectiveness. And that's what this research is going into, but I can't summarize this all at this point. So I hope I've given you kind of a cross-section of some of the cognitive research that's going on right now and things you need to know to help intervene perhaps, or at least recognize problems. I'll take some questions.
The first testing that you do is about what age for cognitive?
At age 5, I think it's really important to test kids at age 5 because we can identify areas of need before they hit their formal education, and we can really inform that IEP process. I like to see kids again then about 4th grade.
Oh, so if a parent is concerned that there's more surfacing, you can test again before the routine at 4th grade?
Yeah, you can track it over time a little more carefully too. But oftentimes that's all it takes is to really educate the school and the family on what these learning problems oftentimes look like and make some recommendations. The math one's really hard to intervene with, if I'm being entirely honest. We know more about the reading problem and how to intervene with that, and schools are more familiar with that and comfortable with that. But the math one is tricky. One of the intervention programs you can recommend for math problems, though, is pirate math, like ARG, maybe, pirate kind of thing. But it's a program that seems to have some evidence behind it that is being used with kids with spina bifida to some effect. And that's something that Marcia Barnes has suggested might be helpful. Are there, yes?
I asked a question about this earlier relating to motor function, but have you seen any more recent studies on intrauterine surgery or intrauterine interventions and its effect on cognitive outcomes?
Yeah, so wait, did someone talk about the MOMS trial?
We just said
Not
that
a-
they're still, we just said that we have limited information.
We have limited information, but it's looking fairly positive certainly in terms of motor functioning. There's less indication that it's, the panacea for cognitive functioning. And, when we think about the cognitive phenotype, it kind of makes sense because that early intervention in utero is not going to change the Chiari or the callosal dysgenesis or even that tectal beaking. So those pieces may still be there, but you may have better motor functioning because you intervene early. Great question.
So thank you all for coming, and we hope that you gained some valuable insight into spina bifida and the multiple issues that occur in this population. And there's actually an evaluation form in your handout, and we would really appreciate any feedback and comments for future seminars. Thank you so much.